Hey everybody, this is Rishi Agrawal, and in this video I'm going to be talking about nontuberculous mycobacterium infection. This is a disease whose prevalence is increasing worldwide, so it's important for radiologists to know the appearance. This is the roadmap we're going to be looking at today, and before we get into the imaging appearance, I want to first talk about taxonomy and classification, how you can get the infection, and then we'll talk about the two main forms of infection in the lung. And then we'll talk a little bit about how the diagnosis is made and imaging choices and other things that can look like NTM. So first of all, what is nontuberculous mycobacterium or NTM? Let's start out at a really high level and talk about how we classify this disease. So remember from biology that we have genus and then species. And the genus that we're talking about is Mycobacterium. And then within that genus, we have a few different species that cause specific diseases, like tuberculosis causes TB. Leprae and lepromatosis cause leprosy. Now, these three species are not included in the nontuberculous mycobacterium species. So everything else is considered nontuberculous mycobacterium. And in this group, there's over 160 species. Not all of those will cause disease in humans. And of the ones that do cause disease, there's different levels of pathogenicity. Now, probably the most relevant way to subclassify the NTM species clinically is to talk about the slow growers and the fast growers. Keep in mind that this is just an abbreviated list. The Mycobacterium avium complex, or MAC, are part of the slow growers, and in the United States, these are the species that are most commonly encountered. They're grouped together because they're closely related in terms of their environment and clinical syndrome. And initially, the two species in this group were M. avium and M. intracellulare, but others have been added. The other one I want to point out is M. kansasi, which is another common species found in the United States. This causes an infection that can be indistinguishable radiographically from TB. Now, I mentioned the most common species in the United States, but if you live in other parts of the world, then the species that are most common in your area might be drastically different. For example, if you take a look at this graph, which was published in the European Respiratory Journal in 2013, it shows the distribution of NTM species in multiple different countries. And the relevant takeaway from this is that even in neighboring countries, the prevalence in these samples can be quite different. So in some places, MAC might be the predominant species, but in others, it's not. So for example, if you look at Austria, 40% of cases are due to MAC, which is this dark blue color. But in neighboring Hungary, it only accounts for 16%, and the majority of cases are due to M. genopi. Now, how do people get the infection? We know that the bacteria are found pretty ubiquitously in soil and water supplies. People have also done studies on shower heads and have found the bacteria there. What we don't really understand well is, given how ubiquitous these bacteria are, why don't more people get it? In other words, why do some people get the infection and why do some people not get the infection? There's some risk factors that we know about, like genetic and molecular risk factors, but we're still trying to understand how and why some people get it and some people don't. In addition to lung disease, NTM can cause a few different forms of infection. You can have a lymphadenitis, which is frequently in the pediatric population, with head and neck lymph nodes most common. You can have a skin and soft tissue infection that's been reported to be caused by contaminated needles, tattoo equipment, or contaminated surgical equipment. And then you can have a disseminated form that occurs in severely immunocompromised patients. Now, this being a thoracic radiology channel, we're going to be talking about the lung disease. And the lung infection comes in a few different forms. You can have fibrocavitary disease that affects older men with pre-existing lung disease, usually emphysema. You can have a nodular bronchiectasis form that affects older women, usually without pre-existing lung disease. And then you can also have a hypersensitivity pneumonitis form, which is not really an infection, and I'm not going to cover it here because it looks like hypersensitivity pneumonitis. It's also called hot tub lung. Now, the thing that separates nontuberculous mycobacterium apart from other community-acquired pneumonia is that it's a chronic infection. So for community-acquired pneumonia, you see an opacity. The patient gets treated with antibiotics, and then 6 to 8 weeks later, you'll get a chest CT or a chest X-ray, and the opacity will be gone. That's not the case with these infections. First of all, not every patient is treated because the treatment consists of multiple drugs, and it's based on the specific species of Nontuberculous Mycobacterium that's isolated. And those drugs have to be taken for many months, typically over a year. And there are significant side effects that are associated with these drugs. And for the patients who don't get treated, you'll just follow them for years and years. And typically these patients will not resolve the infection on their own if they don't have antibiotics. And for those patients who aren't treated, you'll see areas of infection that get a little bit better on one scan, but on the same scan, there's going to be another area that gets a little worse, and they'll just kind of chug along like that. Okay, so for both of these forms, fibrocavitary and nodular bronchiectasis, these represent chronic infection. Now, let's delve into each one a little bit more. Now, let's first talk about the nodular bronchiectasis form. You may have heard some people use this term Lady Windermere syndrome in place of the nodular bronchiectasis form, and I'd rather that you not use this term. This name, Lady Windermere, comes from a play. The main character, Lady Windermere, was this very sort of prim and proper woman who adhered to social conventions. And the term was coined by this paper in 1992, and the authors of this paper called the disease Lady Windermere syndrome because they thought that it occurred in elderly women who suppressed their cough, and that's how they got the disease. Now, first, this hypothesis is not really accepted today. A number of risk factors have been described for NTM, like body morphotype, multiple gene abnormalities, and pre-existing bronchiectasis. Second, this form of the disease, the nodular bronchiectatic form, is more common in elderly women, but it can also be found in younger patients and in men, so it's a bit misleading to call it Lady Windermere's. And then third, the disease sort of implies that it occurs in patients from a higher socioeconomic class, but it occurs in people of all socioeconomic classes. So take a look at this data for a second. This was an epidemiologic study looking at the rates of NTM in the state of Wisconsin. And this graph shows cumulative incidence per 100,000 people on the y-axis. And on the x-axis, it breaks it down into something called the ADI state rank score. ADI stands for Area Deprivation Index, which is a measure of socioeconomic status. And 10 are the poorest people, and 1 are the wealthiest people. And what it shows is that the people in the lowest socioeconomic groups have, in general, higher rates of incidence of NTM. This graph also shows that in most of these deciles, blacks, which are represented by these third black bars here, and in particular Asians, who are represented by these gray bars, have much higher rates of NTM than whites, which are these white bars with dots. So anyway, that's a long-winded way of me telling you that I want you to be aware of the name Lady Windermere syndrome, but I would prefer that you not propagate its use and just call the disease Nontuberculous Mycobacterium. Okay, let's take a look at some examples of the nodular bronchiectatic form. All right, let's start out with a chest X-ray, and I'll tell you that the findings are pretty subtle here. Let me zoom up here on the right lower lung. And what we have is some slight reticulonodular opacity in the periphery of the right lower lung. When we look at the left lower lung, we have mild reticulation with suggestion of bronchiectasis down here with these areas of tram tracking. It's very subtle. And then the last finding on this frontal view is that we have slight bit of obscuration of the inferior right heart border right here, and a bit of obscuration of the left heart border right here. When we take a look at the lateral view, you can see that there's abnormal opacity here in either the lingula or the right middle lobe, and we have this band of opacity here in one of the lower lobes. Now, based on this, I don't think I could definitively say that this is nontuberculous mycobacterium, but the distribution of disease with disease in the lower lungs and in particular the middle lobe and in the lingula, I would certainly be raising the possibility of nontuberculous mycobacterium. Let's take a look at the CT. Okay, this CT was done shortly after that chest x-ray, and already in the upper lungs, you can see that there's some areas of what looked like distal mucus plugs or tree and bud opacity up here as well. And then as we go down, you could see that those findings become more prevalent and more conspicuous. And then when we get down to the middle lobe and lingula, there's a little bit of bronchiectasis down here in the right middle lobe medially. So you could see why the right heart border was obscured. And then we have a similar finding down here in the lingula with a little bit of bronchiectasis. That confirms our finding that we saw in the chest x-ray. You can see that in the adjacent left lower lobe, there's a bit of bronchiectasis with mucus plugging right there as well. And then we see that there's this band of volume loss in the left lower lobe associated with a nodule, which is probably another mucus plug. That correlates with our finding in the lower lobes on the lateral view. Now, I mentioned earlier that this is a chronic infection, so I want to demonstrate that here. So this is the patient 1 year earlier, and you can see that the areas that had tree and bud opacity on the study I just showed you, there was tree and bud opacity in the exact same location on the study from a year prior. And that's typical for these patients with NTM. They'll have tree and bud opacity that just does not really change even on a long-term basis. So this area of tree and bud opacity in the superior segment of the right lower lobe is there. And let me just bring up the current study again. Here it is on the current study again. So these areas might get a little worse and a little bit better, but they typically will not completely go away. And just to illustrate that even further, here's the patient 2 years ago. And again, you see these areas of tree and bud opacity in the superior segment of the right lower lobe. And then we also have the bronchiectasis in the middle lobe, bronchiectasis in the lingula with mucus plugging. Okay, so this is truly a chronic infection, and by chronic, I'm talking years. So notice some things that we don't see here. One is we don't have pleural effusions. Okay, Nontuberculous mycobacterium is typically not associated with pleural effusions. So if you see pleural effusions, you need to think about a superimposed process or a different disease altogether. And then when we go to the soft tissues and we're looking for lymph nodes, notice that we don't really have enlarged lymph nodes in the mediastinum or hyla. This is a pericardial recess right here, not a lymph node. So this disease is not really associated with lymphadenopathy in a patient who has a normal immune system. In a patient who has HIV, then you can see lymphadenopathy, and you may not simply see lymphadenopathy in the mediastinum and hyla, but you might see disseminated disease with lymph nodes in other areas of the body as well. Let's take a look at another case. Here's another patient with nontuberculous mycobacterium. They were a smoker and they have a little bit of emphysema. They also may have pulmonary Langerhans cell histiocytosis because some of these little holes look like they could be bizarre-shaped cysts. Now, as we go down, you can see that we start to see a little bit of tree and bud opacity right here in the right lower lobe, down here posteriorly. And then as we continue inferiorly, we see this area of consolidation. Now, patients with NTM, when you have an area of consolidation or ground glass opacity, that may represent an exacerbation of the nontuberculous mycobacterium infection, but it may also just simply represent community-acquired pneumonia. And I can't really tell the difference just based on this one study. The other thing to note about this case is that it is right lower lobe predominant. We do have disease here in the middle lobe and a little bit in the lingula as well, but not all cases will have that classic middle lobe and lingular predominant disease. Here's a third patient with a nodular bronchiectasis form of NTM. This patient has more advanced disease, and on the chest x-ray, you can easily see extensive reticulation in the lower lungs. It's a little bit more prominent in the right lung compared to the left. Down here, you can see these elongated, lucent structures which represent bronchiectasis. And then we also have obscuration of the right heart border and ill definition of the left heart border. On the lateral view, note how thin the patient is, which is typical of Nontuberculous Mycobacterium. And then we have this opacity here that is in the middle lobe or lingula with bronchiectasis. And then it's hard to see where the minor fissure is, but I think it is about right here. And the major fissure is right here, so we have significant volume loss in the right middle lobe. When we go to the CT, which was performed the same day, you'll see there's a bit of consolidation, ground glass opacity here in the right upper lobe, more consolidation, more ground glass, a lot of tree and bud opacity, a lot of bronchiectasis, and then we get into the middle lobe, which is just completely covered with bronchiectasis and volume loss. Inferior lingula, not as much as the right middle lobe, but there is some bronchiectasis there. And again, these just small areas of nodular consolidation, bronchiectasis, tree and bud opacity. The other thing to note here is look at the difference in the density between the right lower lobe and the left lower lobe. The right lower lobe has more disease, and we don't have expiratory images on this study, but if we were to do an expiratory, I could tell you that these areas of lower density in the right lung will remain low in density compared to the left lung. So remember that Nontuberculous Mycobacterium is a disease of the small airways, so we expect these patients to have some degree of expiratory air trapping. All right, let's switch to the fibrocavitary form of the disease. Now, as opposed to the nodular bronchiectatic form, the fibrocavitary form is more common in men, and these patients tend to have abnormal lungs to begin with. Usually that's emphysema and bronchitis, but it can be other things like occupational lung disease and sarcoid. Now in this example, this is a female, but if you look in the left upper lung here, you can see that there's this asymmetric opacity compared to the right side. Both sides have a little bit of fibrosis, but on the left side, there's too much opacity here. And at this point, it's difficult to say whether this is a mass or a consolidation or what exactly it is, but I would certainly be concerned about malignancy here. Now, when we go down to the bases, you can see there's a little bit of hazy airspace disease and reticulation down here on the right, as well as the left. We also have a little bit of obscuration of the right heart border here. When we look at the CT, in the left apex, you can see that there's this irregular, thick-walled cavitary lesion with these little projections inside the cavity. Just inferior to the cavity is this kind of wedge-shaped area of consolidation. Now again, just based on imaging, it's hard to tell whether this is due to infection or lung cancer. And certainly this patient has significant amount of emphysema, so I would be very concerned about lung cancer because I know that this person is a heavy smoker. When we get down to the lower lungs, you can see that there's, first of all, a little bit of fibrosis in the lower lobes with honeycombing. I would call this a UIP pattern. And on top of that, we see some areas where there's kind of clustered nodules and tree and bud opacity. It's subtle, but it's certainly there. And that's an indication that this person has small airways infection going on. And you can see why the right heart border was obscured on the chest x-ray. We have sort of clustered nodules and a little bit of consolidation down here in the medial right middle lobe. Here's a follow-up of that patient. Tissue sampling was done and there was no malignancy found. This was approximately a year later, and you can see that the cavity has overall increased in size, but the amount of soft tissue associated with the cavity is much smaller. So that's a reassuring sign also that this is not cancer, but infection. These patients with the fibrocavitary form of NTM present differently. They have greater morbidity, and they're also treated differently. So it's important in your report to mention the cavities and mention that this is the fibrocavitary form of Nontuberculous Mycobacterium. Here's another patient with the fibrocavitary form of NTM. So on this chest x-ray, if we zoom in on the left upper lung, you can see that there's a paucity of lung markings here in the upper left lung. And so that's an indication that this patient has emphysema. We also have a big bulla here in the medial left apex. And then if we go over to the right, you'll see that there's this asymmetric airspace opacity in the right apex with this central area of lucency and some adjacent pleural thickening. So a CT was done for this patient, and on the coronal images, first you can see the emphysema in the upper lungs. There's that big bulla in the medial left upper lung, and here's that cavity in the right apex. And when we go to the soft tissue windows, you can see that there's a little bit of pleural thickening, and it's pulling in the extrapleural fat right there. Here's what it looks like on the axials. And again, for this case, I'm not really sure if this is a lung cancer or an infection. And even if I were to favor infection, lung cancer is not far down on the list. So that would have to be excluded in this patient, particularly given their risk factors. This turned out to be Mycobacterium kansasi, and as I mentioned before, that particular species can look exactly like Mycobacterium tuberculosis. This patient was treated with antibiotics, and the antibiotic regimen in these patients is not simple. It's usually very long, lasting more than a year, and a lot of patients can't tolerate the side effects, so treating these patients is a big deal. But this patient was treated, and you can see that the soft tissue component of this cavity is significantly improved. It's not fully resolved, but you can see there's significant improvement here. I want to show you one final form of the disease that you can see occasionally. It's not very common, but you might encounter it from time to time. It's the solitary pulmonary nodule. So this patient, you can see here, has a nodule in the right middle lobe. This nodule has smooth borders and some areas of spiculation, which make it a little bit concerning for lung cancer. We don't have the telltale other signs of nontuberculous mycobacterium here. We don't have tree and bud opacity. We don't really have bronchiectasis. We have one area of possible mucus plugging right next to it there, but that's really not enough to hang my hat on. In addition to infection, I would have to be concerned about lung cancer, and that was the clinical concern as well. So this patient was biopsied, and it turned out to be MAC. Here's a CT of the patient a couple years later, and you can see that the lesion has significantly decreased in size. Okay, I just want to talk for a second about how the diagnosis of NTM is made. These are the clinical practice guidelines that were published in 2020. And if you scroll down to Table 2, it shows the clinical, radiologic, and microbiologic criteria required for the diagnosis. The clinical criteria are pulmonary or systemic symptoms. The radiologic criteria are nodular or cavitary opacities on chest radiograph or a high-resolution computed tomography scan that shows bronchiectasis with multiple small nodules. And then the microbiologic criteria are one of three possible things here. Now, my suggestion as a radiologist is if you have a patient who you suspect of having NTM clinically, and you do a chest x-ray that shows the classic middle lobe and lingular predominant disease with bronchiectasis, I think that is sufficient to make the diagnosis. But for a follow-up, I would suggest doing a CT scan. And the reason is it's much easier to tell whether a patient is improving or getting worse on CT than it is on chest radiograph. And then the other reason why I prefer chest CT over chest X-ray is oftentimes that middle lobe and lingular predominant disease is not what the patient presents with, and you have disease in other parts of the lung. Well, in those cases, it's going to be really hard to differentiate NTM from other types of infection or other bronchiectasis syndromes. And if the patient is presenting with the fibrocavitary form of the disease, as I just showed you, it's really hard to tell the difference between a cavitary NTM lesion and cavitary lung cancer. So in most cases, I would suggest doing a chest CT, which can be done non-contrast, rather than doing chest X-ray and following the patient with chest X-ray.
Let me show you some cases that might be in the differential diagnosis for NTM.
First of all, you can see that this patient's lungs are relatively normal. They have a bit of bronchial wall thickening, but as we go down to the bases, you can see clustered areas of tree and bud opacity, like for example down here, and in the left lower lobe down here, over here. Now, this could be a person who you might suspect nontuberculous mycobacterium, but there's a few key differences. One is that these areas of tree and bud opacity also have a little bit of ground glass surrounding the nodules. So to me, that is indicative not of a chronic indolent process, but a more acute process. And then the second thing is, if you have prior studies to compare to, what you'll notice is that this patient will have normal lungs on the prior, and a patient with nontuberculous mycobacterium typically will have some findings of NTM on the prior study. The other major difference is even in a patient who has recurrent aspiration. Usually from one scan to the next, a patient with recurrent aspiration will have tree and bud opacity in different areas of the lung, whereas in a patient with NTM, the tree and bud opacity is frequently in the exact same position as it was on the prior study. So this patient might have lower lung predominant tree and bud, but rather than it being in this location, it might be in the lung right next to it. So those are some ways you can differentiate chronic recurrent aspiration from NTM. All right, here's a patient with another thing in the differential diagnosis. The first thing you'll notice is that this patient has situs inversus with the heart apex on the right side, the aortic arch on the right side. When we go to the lungs, you can see that there's lower lung predominant reticulation with some tram tracking here that indicates bronchiectasis. On the lateral view, again, you can see this lower lung predominant disease with bronchiectasis and reticulation. Now, the situs inversus gives away the diagnosis here, but if we just had the lower lung predominant reticulation and bronchiectasis, it would be pretty hard to differentiate this from nontuberculous mycobacterium. This is a patient with cartaginers, which is immotile cilia plus situs inversus. Now, if we didn't have the whole cartaginous syndrome, we only had the immotile cilia with normal situs, then the diagnosis becomes a little bit more difficult. Let me just show you what the CT looks like. All right, here's the CT of that patient, and you can see that in the lower lungs we have pretty extensive bronchiectasis on the left and a lot of tree and bud opacity in both lower lungs. Now, this patient, as I said, has immotile cilia, and the distinction I want to make here is what is causing the bronchiectasis. So patients with the nodular bronchiectatic form of NTM usually will have infection in relatively normal lung. But NTM can also occur in patients with other bronchiectasis syndromes like immotile cilia or cystic fibrosis, for example. The question is, what is causing the bronchiectasis? In this case, the bronchiectasis is not because of NTM. The bronchiectasis is being driven by the immodal cilia. In other words, that's the primary diagnosis. And in this case, if we didn't have the situs inversus, we would still have other extrapulmonary findings that will lead us to the diagnosis of immodal cilia, like chronic rhinosinusitis, like otitis, and these patients frequently have fertility issues. Let's take a look at another case. Here's another patient with bronchiectasis, and as we scroll down, you can see that there is bronchiectasis with these thick tubular opacities in the left upper lobe. And when you go to the soft tissue windows, some of these tubular opacities are high in attenuation. This is what's called high attenuation mucus plugging. So the diagnosis here is ABPA, or allergic bronchopulmonary aspergillosis. There's a few major differences between ABPA and NTM. The first is that the lung affected in ABPA, in terms of the bronchiectasis, is pretty central compared to the distal airways that are first affected in patients with NTM. So rather than having these large areas of central mucus plugging that we have here, you have distal tree and bud opacity in NTM. The second way to think about the distribution is what part of the lung is affected. In NTM, in the nodular bronchiectatic form, you have lower lung predominant and typically middle lobe and lingular predominant disease. At least that's where the majority or the most severe disease typically is. But in ABPA, it's not usually middle lobe and lingular predominant. It's usually upper lung, although it can be lower lung, it can be unilateral, it's kind of all over the place, but you don't have that middle lobe and lingular predominance that you have with NTM. And then finally, that finding I mentioned of high attenuation mucus plugging is a pretty specific sign that indicates that this is a fungal etiology, and in particular, ABPA. That's not something that you'll see in patients with NTM. On this chest x-ray, we have an asymmetric opacity in the left apex. When we zoom in, it does look a little bit cavitary with opacity on the periphery of the lesion and some central lucency. This is the CT of that patient, and as we scroll down to the lesion, you can see that there's a cavitary mass here in the left apex, and we have eccentric nodularity along the medial and lateral walls of the lesion, as well as the inferior wall, rather than the more uniform wall thickness that we had in the patients with Nontuberculous Mycobacterium. Now, this patient, I would be more concerned about lung cancer than infection, given these areas of eccentric nodularity. The other finding here is that we don't have the superimposed emphysema or bronchiectasis. This person's lungs are relatively normal compared to the other patients who had fibrocavitary Nontuberculous Mycobacterium. The last finding on this patient is that we have enlarged lymph nodes on the ipsilateral hilum and mediastinum, and that's not something that you'll typically see in a patient with Nontuberculous Mycobacterium, even in the fibrocavitary form of the disease. So for those reasons, I would favor this to represent lung cancer over Nontuberculous Mycobacterium. Another thing to keep in mind in the differential for a chronic cavitary infection is chronic pulmonary aspergillosis. And I don't really have a good example of my own, so here's some from the literature. This is from the European Journal of Radiology in 2024. And chronic pulmonary aspergillosis can be subdivided into multiple different forms, but typically it affects patients who, similar to fibrocavitary NTM, have abnormal lungs to begin with. So you can see that this patient has some sort of fibrotic lung disease here. And on the right side, they have this kind of consolidative opacity that's associated with fibrosis that later went on to show cavitation. This would be very difficult to differentiate from the fibrocavitary form of NTM. And then the final thing to think about, which I'm not going to show you an example of, is just regular Mycobacterium tuberculosis. And as I mentioned before, M. cancesi can look identical to MTB. So the only way to reliably tell the difference is by sampling. There's no way you can tell by imaging. All right, I'm going to wrap this video up. This was a big topic, so if I missed anything, let me know in the comments below. Also, if you have any questions about this topic or any other radiology topic, let me know. Thanks.